am the medical director of HeartLife. I guess that's the important things for today. And I'm really happy to answer any questions that any of you guys might have about, about heart failure in general, but I suppose the purpose of this is to talk about heart failure and COVID. So since I can't hear you, it might be worthwhile to have you guys write your questions in the chat box. So for those of you who aren't familiar with this, there is an icon at the bottom of your screen and it says chat. And if you click on that, you'll be able to just type in questions. And what you want to make sure is that those questions are posted to everybody. So you can either send them to me privately or you can post them to everybody. But I think it's really helpful if you post them to everybody so that people can understand, one, the question that's being asked, but if they want to sort of contribute to that commentary or that dialogue, everybody can sort of see what's going down the side of the screen. So I have from Janet Gates. I am currently working from home and my husband is being home for 2 weeks, but his work, which apparently is deemed essential, car dealership, are going to open next week and he will be going back to work. How do we deal with our living arrangements in a small home with one bathroom to ensure safety? Well, I wish I had some really smart answer about that, but I think it's going to be pretty much what most people are going to suggest, and certainly what Bonnie Henry, public health officer, would suggest, is that to really try and maintain as much sort of hand hygiene and oral hygiene and respiratory hygiene as you possibly can. He's going to bring stuff home because he's going to work, or he has the potential of bringing stuff home because he's going to work. And so I'll tell you what I do when I go to work in the hospital, obviously a place that's full of germs, and I have 4 children and a wife who are at home through all of this. So here's my regimen. I go to work in an outfit or a pair of jeans and a t-shirt. I get to work. I switch into hospital greens and a pair of shoes which stay at the hospital. So I change into that. And then at the end of the day, I change out of that. The shoes stay at work and I change back into the clothes that I came with, go home. And my wife basically has a straight shot for me to go from the back door or the door.
Can anyone hear me?
To our bathroom and so I don't have to touch any doors. So I go straight from walking in the door into the bathroom, have a shower, and then only after that do I kind of come out and give my kids a hug. So, I mean, to your question, it's going to be really about coming up with individual strategies that can protect you from whatever it is that your husband is exposed to at work. And social distancing isn't going to necessarily work in your home. He's your husband, and you're going to spend time together. But what you want to do is minimize your exposure to whatever it is he's bringing in and out of the house. I hope that answered it. I've had cardiomyopathy for 8 years with an ejection fraction of 34%, but never experienced any fluid buildup on my lean figure. I recently went up 2 pounds, but figured it was from staying home all the time and eating more. I went down a couple of days later. What should I do if it increases again? Okay, Jennifer. So it's challenging to figure out. I think the underlying thing here is whether or not your weight gain is related to a heart failure exacerbation, or whether it's related to, just increased eating because everybody's at home, and probably decreased exercise because everybody's at home as well. So I think there's a couple of different points there. One is, you're going to be eating more, potentially eating more, but you also have an opportunity to be really thoughtful about your diet and control diet in a way that previously people have been unable to do. I mean, we go out, we work, we have lives, and salt and fluid intake is challenging at the best of times, but now is really an opportunity to embrace that and make sure that you're really restricting your salt and fluid intake and being very diligent about it, because you're probably cooking everything from home. The other part of that equation, of course, is exercise. And I think that's a big challenge, particularly, getting out and being able, there's no gyms to go to unless you have the luxury of a gym in your own home. There's not a lot of options other than going out for a walk or a bike ride or something like that. And even at that, in my neighborhood, certainly it's hard to keep social distancing on the paths and in the parks because there's so many people out trying to do the same thing. So coming up with a regimen that is going to be cardiovascular in nature, that'll allow you, back to Jane Fonda's workout for those of you who can date yourself. But that's what we need is strategies that will allow you to continue to stay engaged in exercise.
Is there anybody at the other end?
Whether that's, by
we can hear you, Janet. I'm just turning
that walk. But
it's okay. We can hear you, Janet.
It's not working.
Things that are going to factor into this equation of weight gain and are going to sort of confuse the picture because of diet and exercise. Now, I'm sure that's not exactly what you're asking. What you're asking is, how do you tell whether this is heart failure exacerbation or not? I think the fluctuation that you talked about, going up 2 pounds, is sort of at the cusp of what we would expect over the course of a day.
Told to go on to
certainly when that hits 5 pounds over 3 days, then we would be concerned. Nobody really gains fat or muscle that quickly, or loses fat or muscle that quickly. So if you've gained 2 pounds and it's continuing to rise and doesn't go back down, then I would think that would be fluid weight, something that should trigger that you be in contact with your healthcare provider. Or some of our patients are already on diuretics and will have sliding scale, if you will, instructions to take their diuretics as required, or if they gain a little bit of weight, take an extra diuretic. That's not a blanket statement that I want to make for everybody on the phone today. It's something that we have a specific and deliberate conversation with our patients about before we instruct them to do that. So if your weight is going up and it's continuing to rise and you've got 5 pounds over the course of 3 days, then certainly I think that's fluid and should be something that you reach out to get some guidance around. I seem to have started menopause in the last 2 weeks, and I'm concerned about hot flashes and my extreme hypotension. I'm guessing so I don't know much about menopause. I'll be honest about that. But I think what you're asking me is that in the context of COVID and whether or not hot flashes can be associated with that. Or whether, how do you tell the difference between a hot flash and a fever due to COVID? I mean, my understanding, okay, I'm going to suggest some ignorance on this, but my understanding of a hot flash is it's drenching and it's a wave, and it's not subtle. I think what we need to be careful about here is sort of differentiating that from, when you have the fever or flu. And the fever or flu type of fever is not this intense, all of a sudden, hot, episode that comes and goes. It will persist. A lot of, and it doesn't necessarily have what we refer to as a diurnal variation. So when you go to bed at night or any other type of the day, it can come, it doesn't have a time that it comes and goes. So I think that's important to think about and to track. Like, when are your fevers happening? Is it truly a fever when you're having a hot flash? When you take your temperature, or do you have a fever? Because that isn't necessarily going to be the case for all women who are having hot flashes.
Is there anybody there?
That hot flash is associated with a fever, and if it is associated with a fever, then what is the pattern of that? Because if it's going to be COVID, it doesn't necessarily be this evening or when you go to bed or something like that. The other
Janet, I just heard you say, is there anybody there? Did you hear me at all?
COVID shouldn't be giving you hypotension unless you are extremely ill. So I'm going to suggest that the patients who are in the intensive care units are the ones that are having hypotension. So if you are walking about and around and living your daily life, and all of a sudden you get this drenching sweat and your blood pressure goes down, that's going to be more likely due to menopause. If you are having constant fevers and if you are coughing and having all the other symptoms of COVID and your blood pressure is low, then that is something you seek urgent medical attention for. Although the main target of the virus is the lungs, the virus can attack the heart. What if the heart is already compromised? What does this mean for heart failure patients? That one came from HeartLife, so you might not be able to see it. So the main target of the virus is the lungs, but there is an increasing understanding that there's complications from the heart related to the heart in patients who have COVID. So some of that might be just your lungs are in so much stress that it in turn puts stress on the heart. That's one component of it. And then the other component of it is that the virus could potentially attack the heart, or alternatively, there's this sort of stress cardiomyopathy, we refer to it. And basically what that means is when the body is under so much stress that the heart begins to poop out. So there's lots of different things. The patients with COVID are more susceptible to arrhythmias as well. And that's what we see commonly. So it's estimated that about 20 to 25% of patients who have COVID significant enough to get admitted to a hospital or into an intensive care unit will have cardiac manifestations. And I think that's an important thing to remember, is that the only people that we know this is happening to are those that are hospitalized. Right? So I don't know what's happening to people who are just walking around and staying at home with mild symptoms, whether there's any cardiac issues related to that. And I would suggest, though, so that when we say 20 to 25% of people, that's 20 to 25% of the hospitalized people. It doesn't necessarily mean 20 to 25% of people who get COVID, because we don't know what happens to them. They're generally not seeking medical attention. We're not doing litany of tests on them. So we don't know. It could very well be that that group of people have no cardiac complications. And really, it's those with the severe disease that have the cardiac complications. So we're learning a little bit more about what these complications are. They, frankly seem quite severe. And there's some recent data published in large journals like the Journal of the American Medical Association, which show that if you do have a cardiac complication and you have COVID, that your outcome is going to be significantly worse than if you don't have a cardiac complication. So it seems to be a marker of those people who are going to have good or bad outcomes. And right now, the management of that is going to be really based on what manifestations the patients have, whether it's a direct complication or whether it's a consequence of COVID. So that's important as well. We also know that those patients with pre-existing heart disease, whether that's heart failure or hypertension, for example, coronary artery disease, are at increased risk of an adverse event. So if you start out with a poor heart to begin with, which is many of you, if you start out with a poor heart to begin with, then the severity and complication is probably higher. So it underscores why you guys need to be particularly vigilant about staying out of COVID's way and taking all those precautions. So it's a very genuine concern if you have pre-existing disease, and it is a genuine concern if you develop cardiac disease as a result of COVID, because you are likely to do worse than somebody who doesn't develop cardiovascular disease. Does having the flu shot and both pneumonia shots provide any extra protection if I were to get COVID-19? Not clear. So there's a bunch of work that's is underway with the Centers of Disease Control and then the FDA in the US and others to answer that question. There's also some suggestion that immunization against other types of common things may have some cross-reactivity with the COVID virus. So there is some suggestion that could be the case, but we just don't have the epidemiological data right now. I think this will be something that after the fact we'll be able to go back and say, oh, look at all the people who got COVID, look at how many people died from COVID or ended up in an ICU, and then try and figure out whether or not there was a relationship between whether they had been immunized for the flu or pneumonia versus and whether that improved their outcome from COVID. What is clear, though, is that if you're immunized against influenza and pneumonia, you were less likely to get those things. And as a result, it is the picture is less cloudy when you develop symptoms, because we know that there's a pretty good likelihood this isn't pneumonia or this isn't the flu because you've immunized against those things. It also means that you're less likely to get sort of super infections or combined infections. So many people who get one infection, their immune system is weakened and they develop increased risk of developing a second infection. So by protecting yourself against one, and then those two things sort of are summative, right? You get one infection, your immune system is weak, you get a second infection, and now you're battling two things, and your chance of being successful with that is going to be less. So if we can take one thing out of the picture because you're immunized against pneumonia and the flu, then your body's focused on, for example, just fighting COVID, and you've got more reserve, if you will, to fight against that. Have there been any cases of heart transplant patients who've contracted COVID-19? We hope not, but if any, how drastic have been their symptoms compared to the norm? And could they contract the virus earlier than others or affected quicker because of the immunosuppression drugs? There are increasing reports. I think there's like 2 or 3 cases now I've seen for heart transplant recipients. I'm sure there's more for other organ systems, lungs, kidney, liver, for example. But I've seen 2 or 3 case reports. Again, these are in like the International Society of Heart and Lung Transplant Journal or Transplantation, which is another major journal. And at this point, it doesn't actually seem that their symptoms have been particularly bad. Now, that's what's been reported in the literature. I know of at least 1 patient in Vancouver who's had a heart transplant and got COVID and had a very, very benign course. They were admitted to hospital and required some oxygen for a period of time, but it did not require intubation. They've been discharged from hospital. They've recovered. They've done quite well. So, you know, I think that's consistent with what I'm seeing in the literature is that their disease severity isn't particularly worse than others. I think there's probably a gradation to that, though. The earlier you are post-transplant, the more severe your symptoms could be, and that's because you're more severely immunosuppressed. And then the longer you are post-transplant, the less likely the severity of things could be because your immunosuppression is minimized. So I don't know that there's enough data to make a generalized statement, but I can tell you that in our local, very small experience, it has been pretty, okay. I mean, not benign to the extent that the patient didn't have to come to hospital, but benign in the sense that it was just really some oxygen and they were well and they didn't require any specific therapy other than that. Would a vaccine work the same way on immunosuppressed patients as everyone else? I don't know. It would be exactly like so if a vaccine were to be developed, and it isn't developed as yet, certainly working on it, it would have to depend on whether it's a live vaccine or not. And if it was a live vaccine, there are some limitations in terms of transplant patients and immunosuppressed patients as to when they can get, or if they can get live vaccine, as opposed to a deactivated virus. So we just need to sort of figure that out when it happens, or if it happens, if we get to that. And then by the same token, you can get a vaccine, but it's the body's response to that vaccine which is relevant, right? So that's my kids playing, if you can hear them in the background. That will really depend on whether or not your body mounts an immune response to it. So what you'll see, for example, during the big measles outbreak we had not too long ago, you'd have people say, but I got vaccinated against measles, many years ago. And it's only once and we begin to test them for their immunity that we realize, oh gosh, I know you got the vaccination, but your body didn't develop any antibodies. It didn't take the vaccine, so to speak. And we don't routinely measure for this taking of a vaccine. We just assume we give it to you and that it does its job and then you develop antibodies. And that's not necessarily the case. And that may be not the case in patients who are immunocompromised because their body can't mount a response. So it's one thing to give it, it's the other thing to see whether or not in fact it worked. Is it true that people with BCG TB vaccine can have lesser COVID-19 symptoms? I don't know. I've not heard that. But if there is something that you have heard about that, or something specific that you've read, send it to me and I can have a look at it, or send it to Mark or Jillian or whatever, and we can look at it and see. But that's not something I've heard as yet. Sorry, Pega. If a heart failure patient gets COVID-19, is there a chance that there could be increased damage to the heart muscle? Yes, there is a chance that there could be increased damage to the heart muscle because, as I said, 20 to 25% of people are going to get some kind of hospitalized patients are going to get some kind of cardiac complication. So if you're already starting with a weakened muscle, that cardiac complication could, further damage the muscle. What's not clear, though, is the reversibility of that. Because certainly there's some people who can go to the ICU and go to critical care, and have cardiac complications, and they leave hospital and they do just fine. We see the numbers of recovered patients on the news every day, and Bonnie Henry cites them every day at her press conference. So there are a number of patients that do recover, and their cardiac complications will recover. So it's not at this point clear whether this is a lifelong injury that you're going to be dealing with, or an additive on top of whatever injury you already have, or whether this is just a transient thing, which is a reflection of the fact that you have the disease, much like the lungs. You could have the disease in your lungs, be on a ventilator, and then make a full recovery and go home. You may have some long-lasting injury to your lungs, or your lungs may completely recover. And I think that's probably the same thing for the heart. A question for Facebook. We are an elderly couple. I don't dare go out because of my heart condition. My husband is fit and healthy. He goes out for the groceries, medications, etc. I worry about him doing this. He turned 95 not long ago, and they're on Facebook. That's awesome. I would like to order groceries online, but he says he needs to do this or he would go stir crazy. I think he feels that he is a bit invincible. How do I convince him not to do this? How do you convince him not to do this? You know what? I think the biggest reason to convince him not to do this is because he may feel invincible, but that doesn't make you invincible. And so every time he exposes himself, if he's living with you, he in turn exposes you. In blunt terms, that's not fair. He may have made the decision that he's invincible, but it sounds like by your question that you're not feeling particularly invincible. And I think that's what we really need to remember about all of this. And I struggle in speaking with my friends and neighbors as well, who feel somewhat invincible, who are younger or don't have chronic health conditions, and their relative passive attitude around social distancing and being aggressive about this, is that we need to remember that this is a all hands on deck. It is a societal imperative that we do this. This isn't necessarily about me or you. This is about us collectively. And by doing our individual parts, we are helping to improve and flatten the curve for all of society. So yeah, you may be invincible, but what's really important is that you don't serve as a vector, as a conduit for passing this virus around, and certainly not to your loved ones. So I would say that being the main thing, really looking at the societal impact of that decision as well. It's hard. It's hard. My parents are going stir crazy. They miss their grandkids that they haven't seen in 3-4 weeks now. They're in their 70s, and I've kind of confined them to home, pardon me. And it's really hard for them not to be able to participate with their family and friends and loved ones. So I get it. Are COVID-19 patients who develop heart failure and muscle damage going to be monitored for heart failure on follow-up? I think so. Absolutely. That implies, though, that that's brought to our attention. So if you're a heart failure patient who develops COVID and that information isn't fed back to your cardiologist, your internal medicine specialist, or your heart failure specialist, it'd be really hard for us to be able to do anything or to create structured follow-up around that. So I think it's going to be important to make sure that there's communication, either just by the patient, frankly, telling that person, calling the doctor's office and letting them know, or alternatively through a robust information system that exists at the provincial level where we can begin to track that. The various hats I wear, one of them is the provincial lead for Cardiac Services BC for COVID, and these are discussions we're absolutely having, not just for heart failure patients, but all kinds of other patients. So there's patients who need bypass surgery who are getting bumped because of COVID, and we're not doing procedures, and what happens to them? And then there's also patients who, have been deemed urgent or emergent in terms of needing to have a procedure done, and we call them and say, we want to bring you into hospital to have this procedure done. And they say, I'm not coming into hospital. I don't want to have my procedure done. And so there's another group of patients who are declining a procedure because they're scared, and that's understandable. So we need to understand, 6 months, 1 year from now, how did that turn out? The people that we called up and said, we're canceling your cardiac surgery or your heart procedure, whatever it might be, how did they fare, what happened to them, and whether they have heart failure or not. And those people who called us and said, I don't want to do this right now, how did they fare? Because that'll be informative in terms of how we look at future pandemics. It'll be informative in terms of even looking at how we currently manage our patients and how we triage them and say, you can wait 6 weeks, you can wait 12 weeks. Well, if somebody that we said could wait 12 weeks did fine for 24 weeks, then maybe we had the wrong metric to begin with. And if somebody that we triaged for 12 weeks had a heart attack at 2 weeks, and clearly, again, how we triaged that patient was faulty. So we need to think a little bit about our triage mechanisms, how we prioritize patients, and this is going to give us some information around that. Another from Facebook. How am I more at risk because of my heart failure? My EF is 22%, 49-year-old, otherwise healthy. I get that I am more at risk generally and resources are stretched to say the least, but I've heard the virus enlarges the heart, worsening its function. I'm still walking at least 5K a day, yoga, and staying away from public shops, trying to stay healthy, but should I be outside at all? I'm not an anxious person, but I just want to be wise about my decisions. I find exercise helps my mind for racing, but can I be exercising too much? How would I know? Okay, so that's a lot of stuff in one. Are you more risk because of your heart failure? Yes, that's just the data. Patients with chronic disease, and heart failure is a chronic disease, are at higher risk. Now, that's all comers, right? So we say patients with heart failure. That means some patients with heart failure are going to be an extreme risk, and other patients with heart failure are going to be a milder risk. But on average, patients, if you bundle all the heart failure patients up, heart failure patients are at increased risk. So you're at increased risk because we say patients with chronic disease are generally immunosuppressed. Their immune systems are not as robust as other people's immune systems. And that, again, is very true for patients with heart failure. And that's part of the reason why we recommend that all patients with heart failure get annual flu vaccines, because we know them to be less resilient in terms of fighting off infection or any other disease for that matter. So are you at risk? Yes. It depends, however, there's a number of factors that go into identifying whether you're going to be the low-risk heart failure patient or the high-risk heart failure patient. And you've alluded to a couple of them, ejection fraction and age, and what you've also alluded to is your functional capacity. So it sounds like you are NYHA functional class 1. And those are all good things, right? Being young and high good functional capacity are good things and suggest that you would be at low risk. Your ejection fraction is very low, and so that might put you at high risk. And so we use any number of tools to sort of calculate overall heart failure risk. Those tools are not designed to calculate heart failure risk for COVID, but just, are you a high or low risk heart failure patient? Are you at high or low risk of dying? Are you at high or low risk of having a hospitalization? Are you at high or low risk of sudden cardiac death? And we would use that same kind of methodology, those same tools, to then say, well, if you were high risk for heart failure, for death, for sudden cardiac death, for hospitalization, then you are going to be a high-risk person for probably having an untoward outcome related to catching COVID. So, it's hard to make that assessment with just 3 data points. There's a lot of other things that factor into that. Your blood pressure, your kidney function, what medications you're taking, for example, are all important determinants. And we have lots of scores. The one we use most commonly is probably the MAGGIC score, MAGGIC, MAGGIC risk score. And you can just go online and put in the MAGGIC risk score, and it'll ask for you for your blood pressure, your age, your ejection fraction, your functional capacity, your medications you're taking, your creatinine. There's probably something else I'm missing, but there's like 10 variables. And you can put it in and you'll get a good sense of what your risk of heart failure, hospitalization, or death is. And then you can take that and say, I'm in a high risk category, but I'm on the low end of that. So that would be it. Exercising too much, there's no such thing really, so long as you're doing the right type of exercise. So what I say to my patients is, if you want to build up your biceps, there is no point in doing squats. That's just not going to work, right? You need a targeted exercise for a targeted muscle group. So if I want to build up my biceps, then I'm going to do bicep curls. Well, the heart is a muscle, right? So same idea. You're not going to build up your heart muscle by doing squats or bicep curls. You're going to build up your heart muscle by doing cardiovascular exercise. So that's how we strengthen the heart muscle. So no such thing as too much exercise. But of course, you're going to have to be conscious about where you're doing it and social distancing and all of that sort of stuff. But so long as the exercise that you're doing is cardiovascular in nature, I really don't see any reason why you shouldn't be doing that. Okay. Should cardiac and heart failure patients wear masks when we go out? Yes. Next. No, that's blunt. Yeah, you should be wearing masks when you go out. I really don't see any harm in doing that. I think that that's not something that you've heard from the public health officer as yet, is that people who go out should be wearing masks all the time. But certainly, I think we're probably moving in that direction as a society. You've already seen, for example, the US and Europe, et cetera, moving in that direction. So I would anticipate that we're going to start seeing that more and more for the general population. So I really don't see the downside. Let me be clear though, not necessarily masks. What you need to be doing is covering your face. And so you're seeing this a lot as well. So long, maybe that's just a scarf or a balaclava or whatever, but you just need to be covering your mouth and nose. It's not going to be as relevant unless you're in a healthcare setting, in a hospital setting, that it be like a surgical N95 mask or something like that. It's going to be, covering your nose and mouth in a meaningful way. We're potentially at shortage for our protective personal equipment. You've all heard about that on the news, the PPE. So, I'm very cognizant about giving advice to say everybody should do this and wear surgical masks or N95 masks. That's not what I'm suggesting, unless, Bonnie Henry comes out with that. I'm suggesting that people cover their nose and mouth in the best way possible. If you have a surgical mask already, well, use it, but reuse it, okay? Have the hospitals in Canada experienced any shortages of PPE? It's not my place to speak on behalf of the hospitals because I don't have a sense of the inventory of all the hospitals across the province. But I think it's fair to say that this is something that is of concern, particularly given how long the pandemic goes. And it also relates to what I was just saying, being responsible stewards of the resource. So we need to make sure that those of us who are using PPE are using it in a responsible way and dispose it, and not, sort of in the good old days, you put on a mask and you toss it out, and then you use the next mask and you toss it out, and being better stewards of all of that. So we need to be thoughtful about that. I think it's safe to say that there are concerns about ongoing supplies, and we hear about Donald Trump, and 3M and all that kind of stuff on the news, and those are real things that our healthcare professionals and healthcare systems and health systems administrators.
Jennifer asked about the functional capacity test that you mentioned earlier, Sean.
It's actually not a test. It's called the New York Heart Association Functional Classification, NYHA, and it goes from 1 to 4. And it's basically a sort of a real world test, if you will. It's your ability to exercise or perform your activities of daily living without experiencing symptoms. So NYHA 1 is the highest functional capacity. That is, you're able to do everything you want to do. You're active, you're vibrant, and you have no symptoms. And NYHA 4 is shortness of breath at rest. So you're sitting in a chair and you have shortness of breath. And so in between is really that gradation. So most of us will use the ability to walk 2 blocks or climb 2 flights of stairs as our differentiator. So you may have your healthcare provider ask you that, and you're like, why are you asking me how many blocks I can walk or how many flights of stairs? And that's really to help us gauge your NYHA functional class. So Google it, it'll give you the very clear things, but it's interesting that NYHA class correlates very well with outcomes in heart failure patients. And generally speaking, NYHA class will be an important entry criteria for clinical trials. It'll be a criteria for a lot of drugs that patients need to have, be symptomatic or have NYHA class 2, 3, 4 status before they get treated with a drug. So it's a very good discriminator. There's no more questions. There's some lovely comments.
There are some lovely comments.
I want to draw everybody's attention to the CCS website. So some of the stuff that you guys have talked about today
What is the CCS, Sean?
The Canadian Cardiovascular Society, CCS, has developed a COVID rapid response team. And what that rapid response team is being charged with doing is coming up with pragmatic, policies, solutions, guidance for healthcare providers mostly, although we're talking about changing that, but for healthcare providers mostly, to answer their questions, because we're all kind of learning about this at the same time. I had not heard about COVID prior to a couple of months ago, and certainly had no idea of what the impact of COVID was on the heart. So, we're trying to develop tools and resources that we can use to support cardiologists and other cardiac care providers across the country. So if you go to the CCS, Canadian Cardiovascular Society website, just posted by Mark, there is a whole bunch of COVID resources. And some of the stuff that we talked about, while it is geared to the healthcare provider, it's written in a way that I think many patients and family and care providers would be able to understand. And one of the best tools that just the Canadian Heart Failure Society produced was, is this COVID or is this heart failure? And it just walks you through symptoms and allows you to work through an algorithm of like, this is more likely to be COVID or this is more likely to be heart failure. And I think that's going to be really important for all of you who are battling with heart failure and have fear about COVID as well. Does the virus attack my ICD? No, it shouldn't. We're not, you can have virus in the bloodstream, but, by attack, I think you're probably meaning, can my ICD get infected? Not generally from viruses. Bacteria, yes, but not from viruses. You said something that sounded like MAGGIC about age prescriptions EF. Oh, MAGGIC, 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 the MAGGIC risk score. So go look at it online, and you can calculate it online. It's sobering sometimes, or sometimes it's enlightening and uplifting. But it's a tool I use oftentimes with my patients to help frame the conversation. Sometimes my patients think that heart failure is a death sentence, and then you calculate a score with them and they realize that it's not. And then other patients have very false perception of their prognosis and outcome related to heart failure, and sometimes it's a bit sobering, but it needs to be done because I think you need to have that information to be able to make informed choices. You simply can't make informed choices unless you have all the information in front of you. And so I find it a useful tool. It's also quite useful in terms of, what if I were to get off the couch and go from being an NYHA class 4 to an NYHA 1? What does that do? How would exercise or how would leading a more healthy life actually impact my prognosis? And you can see that very quickly. You move a patient from a class 4 to a class 1, and all of a sudden you're doing a lot better. I mean, I use Mark as an example, Baines as an example of somebody, when I talk to some of my patients that, not too long ago, Mark was, running 10 kilometers. And that, even if you have a really bad heart, when Mark had heart failure, even if you have a really bad heart and you're running 10 kilometers, your prognosis is better than somebody whose heart pumping function is 60%, but they can't walk a block. So, I mean, that's stark, right? That's really interesting. Normal heart pumping function, you can't walk a block versus, ejection fraction of less than 20% and running 10 kilometers. And it's doable, right? You can run 10 kilometers with an EF of less than 20%. And patients would be like, no, that's not possible. No, it is. And I know people who do it. So, so I think that's important in just playing around with that tool and seeing what things you can change and how that could impact your outcome.
It's a great tool. Thank you.
Patients can also go to the BC Centre of Disease Control. Yes, Bonnie, absolutely. The CDC website, I think, is awesome. I think Bonnie Henry is awesome, not Bonnie Catlin, so she's awesome too. But I think Bonnie Henry is awesome. I love the transparency with which she's approached her daily briefings, and she has a wonderful calming nature about her. But the tools that are on that website are really excellent, and there's a real-time dashboard which you can access and look and see how many patients there are in the province on any given day with COVID, how many diagnosed, recovered, et cetera, et cetera. And I think, again, just transparency and knowing is a huge part. And I think the other thing that website will show you is that collectively as a population, notwithstanding our 95-year-old who wants to get out of the house, but collectively as a population in BC, we've done really well. And when you compare the numbers from Ontario, for example, that were reported yesterday, we've had some great success with our social distancing, with our public health policy in BC. And I think Bonnie Henry's and healthcare providers and health systems people, and most importantly, everybody on the ground who's actually carrying out the advice, that we all have something to be very proud of. Any last tips or thoughts from Mark? So there's a lot of hysteria. So I'd say please manage that, right? I mean, this is wonderful what HeartLife has done today to help bring some perspective to it, to bring together a community of people who are all sort of sharing and experiencing the same thing and can support one another. But there is an opportunity for hysteria. I see it in the hospitals as well. People can get whipped up into a frenzy. That doesn't mean that this isn't an important thing and something that we shouldn't be paying huge attention to and being mindful of. But there is this tendency that we could go off on a tangent and and integrate information into our decision making that isn't necessarily founded on data. There isn't a lot of data to be had, and so that's frustrating at this time. But as I said just a few minutes ago, we're learning about this disease. I don't know that any of us knew what this was a few months ago, nor that we knew what the cardiac impact of it is. So to my knowledge, there are no conspiracy theories. It's people are just learning and trying to disseminate the information integrate and disseminate the information as quickly as they possibly can. So don't take things into your own hands unless you've got some good, strong evidence to support that. So I'd say that. There are some great tools. Bonnie's talking about the Johns Hopkins website, again, the CDC website locally, HeartLife, Canadian Cardiovascular Society, really important websites which will have up-to-date tools, hopefully with the best vetted and up-to-date information. So I would say that. What else would I say? Do try and limit your exposure. Really be thoughtful about social distancing. You are a high-risk group of patients. And so wherever you can, stay whenever and wherever you can, stay indoors and try and surround yourself or not surround yourself by people who have external exposures, but surround yourself by people that you know are going to be as thoughtful about their respiratory, their hand hygiene, et cetera, as you. So if you've got somebody in the house who doesn't give a rat's ass, well, you need to separate yourself from that person because they are every day bringing stuff into the home that you don't know about and puts you at risk. So really important to surround yourself with people and to communicate that to the people who love you and the people who are supporting you, how important that actually is going to be for not just their own well-being, but your well-being as well as an immunocompromised person. And then the last thing is, I think, committing to doing this again, hopefully, if the need arises. I suspect it will, as the information evolves. I also think it's going to be really important. This is the biggest time for advocacy around your disease. And believe it or not, there is a burning platform right now. So, I get a chance to talk to so many in the healthcare system at senior leadership levels to come up with strategies. And for the first time, we're talking about strategies to support patients with chronic disease so that they don't fall through the cracks as the whole healthcare system focuses on COVID. Well, what about all these patients with chronic healthcare conditions that still need ongoing care? Otherwise, they run the risk of showing up in the hospital, exactly the place where we don't have capacity for them to be right now. So there's a real focus on developing solutions and tools to support that patient population. And so here's this burning platform. Let's take advantage of it. Let's advocate, because what we create now will continue to be a legacy into the future. And sort of born out of necessity at this time, we can create something that will then have long-lasting impact and legacy moving forward. So the advocacy piece is going to be really, really important, and putting up your hand and saying, I know I don't have COVID. I may not even be at high risk for COVID, but I do have a chronic condition that continues to need care and support. Otherwise, I'm going to end up in the emergency room. So please, what are the resources that are out there for me, and how are my healthcare providers going to continue? How's the province going to continue to provide care for me? Because I don't want to come to the emergency room. I realize there's value, there's need for that for other people. I don't want to come to the emergency room. What are the resources to help me, to prevent me from doing this?
Yeah, absolutely. Well, and you know, as heart failure patients, I'm sure you, well, as heart failure specialist, I'm sure you're well aware that heart failure patients are kind of one of the first ones to end up in emerge. And so anything that we can do to make sure that we stay out of hospital and we can manage our conditions as effectively as we can, and that as doctors and nurses, you guys have all the tools at your disposal. Actually, Jennifer had a great question about how you can help advocate. Please get involved with HeartLife, reach out to Mark and myself, and anybody else who is interested. And the more voices we have, the more people we can have at the table, the greater power we have as patients. And we do have connections with other like organizations, other chronic disease organizations across the country as well, so that we can help leverage our collective voices, but specifically through HeartLife, through our close connection with Canadian Heart Failure Society, Canadian Cardiovascular Society, to really make sure that we get the care that we need. And so I would say, reach out to Mark and myself, and we can take it from there. So Sunny says thank you. Everybody says thank
welcome.
you. Thank you, team. Yeah, we have a really great group of patients, of people with lived experience and family carers. So thank you so much. Dr. Virani, thank you so much for everything today. Sorry for the challenges up front. I guess all it took was for Zoom to kick us out. Thanks for this was our first attempt at doing this. So, you know, we kind of learn as we go a little bit, and hopefully we'll be able to have you back again soon. And thank you so much for everything that you do for us, and you know, for saving Mark's life. We kind of like the guy, and also for saving mine. What do you say?
There you go. Thank you. Stay safe, everybody. Okay, my pleasure.
You too. Bye.
Bye.